World Congress for Physical Therapy's International Physical Therapist for HIV/AIDS, Oncology, Hospice, and Palliative Care. And today we are very fortunate to have Junhong Lim from Singapore presenting on new developments in hospice and palliative care. I was privileged to meet Junhong in Singapore when we had the World Congress this past May, and exchange some, comments about research and the new IPT-HOPE group. So I have Junhong's presentation up, and I will let him continue on. I'm going to mute myself so I don't make any noise here for him. All right, Junhong.
All right. Thank you, Jackie, for the introduction. So, hi everyone. Welcome to the WCPT IPT-HOPE online education session. My name is Junhong from Singapore. It is my honor and privilege to share with all of you today. So, I currently work with Parkway Hospitals Singapore, and previously I was working for the last 6 years with Tan Tock Seng Hospital, and I had the opportunity to collaborate with our community partner, Dover Park Hospice, in the areas of patient care and therapist training over the last 3 years. So during that time, I had learned a lot, and it was during this period of time where the more recent developments, the exciting developments in hospice and palliative care really picked up. So without further ado, I'll go straight to my presentation because I think time is a factor right now. So we'll go straight in. I'll be talking about the new developments in hospice and palliative care physiotherapy, and it will be in terms of the developments in Singapore and a perspective from an Asian point of view. In this presentation, you will learn how Singapore moves up the rankings on a global index on palliative care over the last 5 years to become the second best in Asia. You will identify challenges and opportunities that physiotherapists encounter while managing patients requiring palliative care. Identify education and training needs in the area of palliative care, physiotherapy, as well as to explore cultural aspects of palliative care from an Asian perspective. The WHO defines palliative care as an approach that improves the quality of life of patients and their families faced by the problem associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, be it physical, social, or spiritual. Common life-threatening illnesses include advanced cancers, end-stage organ disease such as heart, liver, and kidney failure, as well as pulmonary conditions such as COPD. It also includes conditions such as HIV and AIDS, advanced neurological conditions such as stroke, ALS, and Parkinson's disease, and as well as advanced dementia. In many cases, rehabilitation for these patients require both a holistic and a systematic approach. The Singapore palliative care movement started to gain acceptance in Singapore in the 19th century. In 1985, 16 beds were set aside for the terminally ill at St. Joseph's Home, a residential institution for the elderly. This initiative was chronicled in the newspaper article, raising awareness of the needs of the terminally ill and highlighting gaps in the care of patients with advanced cancer. Notwithstanding the taboo surrounding end-of-life care that was prevalent at that time, the article mentioned a place where people could be dying and they could be well cared for in that place. The public responded to the article positively with offers of help and leading to the formation of the first charitably funded hospice, the Hospice Care Group in Singapore, in March 1987. The Hospice Care Group became Hospice Care Association in 1989 and is currently known as HCA Hospice Care. Later we'll be hearing more about this association as my presentation goes on. The first hospice that is purpose-built Dover Park Hospice was set up in 1995, along with several home care teams and another hospice, IPT-HOPE and Hospice. Care services were the last to develop, with the first consultative service created in Tan Tock Seng Hospital in 1996. The first Department of Palliative Medicine in a local hospital was created in 1999 at the National Cancer Center. In 1995, the five charities providing hospice services formed the Singapore Hospice Council, an umbrella body set up to unify and develop the palliative care movement. It has made significant headway, not only with the development of more palliative resources throughout the nation, but also the growing recognition in care at the end-stage disease that requires an interdisciplinary approach with integration of care across different healthcare settings. Today, there are 4 inpatient hospices and 7 home care services that provide supportive care to patients in the community. Palliative consultative services were also now provided in all tertiary hospitals in Singapore. In 2010, the Lim Foundation had commissioned the Economist Intelligence Unit to rank 40 countries on the provision of end-of-life care in the Global Quality of Life Index. The index scored the countries on 24 indicators in 4 categories: basic end-of-life care environment, availability of end-of-life care, cost of end-of-life care, as well as the quality of end-of-life care. Singapore ranked 2nd among the Asian countries and 18th overall. Singapore was strongest in the category of quality of end-of-life care, which they ranked 11th out of 40, and they were the weakest in the category of basic end-of-life healthcare environment, where they ranked 30th out of 40 countries. According to the Economist Intelligence Unit report, Singapore's weakness, relatively speaking, includes an increasingly aging population. In 2010, 9% of Singaporeans were above the age of 65. This figure was anticipated to raise to 19% by 2030. In fact, the percentage has already risen to almost 12% this year. Singapore's population is rapidly aging due to a longer life expectancy, the post-war baby boomers going into older age groups, as well as the declining birth rates. The second weakness is the old age dependency ratio, defined as the number of residents aged 20 to 64 years per elderly that is aged 65 years and over. We're seeing a worrying dip in this ratio over the last 15 years, where in the year 2000, the ratio was 9.0 and is steadily declining to 5.7 today. Another relative weakness includes the availability or the inavailability of hospice and palliative care services per million population aged 65 and over, the percentage of deaths touched by end-of-life care, the number of hospices and palliative care services available, the social security expenditure on health, the healthcare spending as a percentage of GDP, and the non-existence of government-led national palliative care strategy. Singapore government is working to catch up following years where it invested relatively little in palliative care. Singapore has one of the fastest aging populations in the world, but until about 25 years ago, we had a young population. So we built up a pretty good acute care system, but when it comes to chronic diseases and end of life, there was a lot of catching up to do. The Health recognized that the country's palliative care needs will escalate over the years and started to promote palliative care on a nationwide level. Other than the problems associated with the aging population and increasing prevalence in chronic illnesses, rising societal expectations with regard to choices and preferences at the end of life create demands for palliative care services that addresses the needs. So the Singapore Ministry of Health commissioned the Lien Centre for Palliative Care to come up with a strategy for the development of palliative care. The report, which was released in 2012, outlined 10 strategic goals. Number 1, all patients with life-limiting illnesses should be identified and their palliative care needs assessed. The second goal, all patients with life-limiting illnesses should be cared for by healthcare professionals using a palliative care approach. Patients with complex needs should have access to specialized palliative care services. Palliative care should be delivered in a coordinated manner that ensures continuity of care across settings and over time. Palliative care should be affordable to all who need it, and quality care should be provided at a cost-effective manner. There should be adequate healthcare professionals with appropriate training to meet the needs of patients at the end of life. Goals number 6, there should be adequate capacity to meet the palliative care needs of patients. There should be local standards of care to ensure that the delivery of good quality palliative care. He also recommended the acceptance and public awareness of palliative care services, advanced care planning, and bereavement services to be promoted. Palliative care research should be promoted to improve the quality of palliative care and to inform policy making. There should be leadership and governance to guide the development of palliative care services in Singapore. So the Ministry, having accepted the recommendations, rolled out the National Guidelines for Palliative Care last year. So this new document spells out that what was required for individualized patient care, how caregivers and families should be supported, including the bereavement period, what is required for good staff and volunteer management, and what is required for safe care. So the Ministry of Health will be partnering the Singapore Hospice Council to promote and implement these guidelines across different care settings. And care providers will get help to meet these guidelines through voluntary self-assessment tools, staff training programs, and quality improvement projects. Next, we will be exploring the different areas of growth as a result of rolling out the national strategy and guidelines. So the first thing is we are seeing that the inpatient capacity is being increased. So the beds for palliative care will be increased to at least 360 beds by 2020, up from the current number of 147. So we're seeing Dover Park Hospice as well as other hospices increasing their capacity. But there were also plans to set aside more beds in community hospitals for patients on palliative care. One such example is St. Andrew's Community Hospital, whereby they started training their staff way beforehand in order to prepare to open up more beds for hospice, inpatient hospice care patients. In Tan Tock Seng Hospital, it opened the very first palliative care ward within an acute care hospital. And I had the privilege of working with the patients in this palliative care ward within Tan Tock Seng Hospital. And we have built up a strong culture among the staff, as well as a rapport with the patients and family to develop palliative care, quality palliative care in this ward. And the close proximity between Tan Tock Seng Hospital and its community partner, Dover Park Hospice, meant that For patients who were previously in the inpatient palliative care ward in Tan Tock Seng Hospital, they could be transferred seamlessly for further long-term hospice inpatient care to Dover Park Hospice, which is across the road. So more and more increasingly, we're seeing this kind of collaborations happening in Singapore, whereby tertiary hospitals partner their fellow community hospitals or hospices in the neighboring vicinity so that they can provide this seamless care. The second area of growth is in terms of home care capacity. So the current capacity of home care is about 5,000, and there are plans to increase it by at least 1,000 more places by 2020. In addition, domiciliary services for the elderly, such as the Hua Mei Mobile Clinic, have started an end-of-life pilot program extending care for patients under their service right till the terminal phase. We're also seeing another example whereby the AIC Home program, which stands for Holistic Care for Medically Advanced Patients. It is a interdisciplinary program that provides home palliative care and advanced care planning for patients with end-stage organ failure. So right now, we're not just limited to cancer patients, we're going towards providing care for end-stage organ failure patients, such as those with heart and lung or kidney failure. The program coordinates care with the other relevant specialists in the acute hospitals, as well as with other community hospice services to ensure that patients are cared for optimally and in the most appropriate setting at different stages of their illnesses. Patients under this program are at risk of developing acute exacerbations such as COPD and also breathlessness as a result of end-stage lung cancer. So this home care program has resulted in improved quality of life and a reduction in unnecessary hospital admissions. This has also enabled more patients to be cared for at home in the terminal stages, which are well in accordance with their wishes. So Project CARE is a pilot program aimed at introducing and implementing palliative care systematically into the 7 voluntary welfare nursing homes in Singapore. It is a collaborative effort of care delivery with the hospital team working with the nursing home team. The key elements of this program are patient stratification, advanced care planning, and partnership in terms of provision of end-of-life care. Skill transfer to nursing home staff promotes sustainability and capability building. To date, it has assisted 700 people in making advanced care plans and has helped to provide palliative care to about 300 nursing home residents. Project Dignity is another interesting development in recent years, whereby they provide palliative care to homebound patients who are suffering from advanced stage dementia. So again, venturing out of the cancer regime, cancer realm, going into dementia care and even end-stage organ failure. So we're really expanding different areas of growth. So in parallel to the creation of palliative care services for adults, there has been increasing recognition of the need to serve the pediatric population in the community. The STAR PALS, which stands for Pediatric Advanced Life Support Program, Singapore's first pediatric palliative care program, was set up by HCA Hospice Care in 2012. The Asian Women's Welfare Association, also known as AWA, has a daycare program for pediatrics with chronic life-threatening neurological illnesses. RCC Hospice, KK Women's and Children's Hospital, they have also strong traditions in pediatric palliative care. In recent years, we're also seeing rehab programs for cancer rehabilitation coming up. So the National University Cancer Institute provides adult as well as pediatric cancer rehab programs. While in the last 2 months, the Singapore Cancer Society opened a new rehab center within a Heartland shopping mall, so that residents and attendees will be able to attend rehab programs more easily, more accessibly, and that also helps them to actually relieve some of the anxiety that they may experience if they were to visit a hospital. This certainly is a new venture, and it will be a new experience to patients going for cancer rehab in a shopping mall. So other areas, including inpatient palliative rehab, we're seeing different hospitals, whether acute, community, or hospices, they are implementing such inpatient rehab programs like the one I spoke to you about, whereby patients may have 1 or 2 weeks of inpatient rehab just to increase some of the mobility issues, just to improve some of the mobility issues that they may have, and they may even go home after a short period of stay in the inpatient rehab. And with partnerships with our community partners, if they were to require any further stay, hospice stay, or transfers to the community hospitals, it can be done. So the next area we'll be looking at will be the current landscape of palliative care education in Singapore. At present, palliative care education for medical, nursing, and allied health professionals is provided by a variety of healthcare and educational institutions. In 2007, palliative medicine was recognized as a specialty, with a training curriculum developed to teach its fundamental principles to postgraduate specialists. Palliative medicine was recently integrated into the core curriculum for undergraduate medical students, further underscoring its importance. The range of palliative care education activities for nurses is more diverse and is offered by a variety of institutions, including the private sector such as Parkway College. Aimed at a whole range of nursing, from nursing aides to advanced nurse practitioners with master's degrees. Advanced specialization in palliative medicine has also been introduced among nurses, with advanced practice nurses playing a vital role in advocating for patients at the end of life. Other than palliative education modules within a generalist nursing curriculum, there are also focused courses such as the Certificate in Basic Palliative Care Nursing run by Dover Park Hospice, Advanced Diploma in Palliative Care Nursing offered by the Nanyang Polytechnic in Singapore, as well as the Specialist Diploma in Palliative Care offered by Ngee Polytechnic. In the area of physical therapy, there was no formal palliative care education or formal palliative care curriculum for physiotherapy in Singapore until recently, where the Trinity College of Dublin partnered with Singapore Institute of Technology to offer a Bachelor of Science in Physiotherapy program in Singapore, teaching topics on cancer rehabilitation and palliative care. In November last year, the same lecturers from Trinity College Dublin, along with other local speakers, were invited to conduct an oncology rehabilitation workshop in Singapore, during which the topic of palliative care was also discussed. More specifically, in October last year, my colleagues from Tan Tock Seng Hospital and I conducted a rehabilitation in palliative care workshop to a group of OTs and PTs in Singapore. So, what are some of the research that we find in terms of physiotherapy education, more specifically in Asia and in Singapore. So according to Ong and Lee, their research found that many physios appeared uncomfortable in managing patients who were receiving palliative care. My own research from 2 years ago investigated the challenges that physiotherapists experience when they manage patients who receive palliative care. So I gave out a survey, conducted a survey to 125 participants from 4 different acute care hospitals to find out what were the common challenges that they experience when they manage this group of patients. So the top few results that came out were that they found that it was difficult to set goals with the patient. Now, bearing in mind that one of the aims of palliative care is to involve the patient and family to target what they want to achieve. But for physiotherapists, they found that it was particularly difficult to decide how far to progress treatment for the patient. It could be due to various factors. The second most common challenges they experienced was that the patients commonly presented already with poor physical conditions, so they could not tolerate any form of physical activity, or in fact, they could. Some of the difficulties that the PTs experienced were how to actually gauge how much to actually push the patients in view of the poor physical condition to start off with. There was also limited understanding of the patient's diseases and prognosis, so that boils down to the basic knowledge of health, pathophysiology, conditions, medical conditions. So that was what was more striking during the research. Fourth factor, emotional burden of the physiotherapist. So this could be due to the fact that working with dying patients required a lot of emotional labor, and it really impacts on the physiotherapist's comfort and confidence in providing palliative care. There could be a sense of futility associated with treatment, which tends not to heal or restore optimal functional levels. They could also see that dying in acute care could be inappropriate in terms of facilities and the orientation of care, because physiotherapists may perceive dying in acute care as inappropriate because the orientation of care tends to be focused on active treatment and potential cure within the acute care settings, whereas right now we're taking in patients in the acute setting who we know are not going to get better. So there's this emotional struggle among local physiotherapists in Singapore as to whether it is worthwhile and whether the conditions, whether the patients will be able to tolerate physical therapy. So this is my research that I presented in the WCPT Congress this year in the Oncology and Palliative Care tract. And one of the findings from my research included what were the education and training needs that physiotherapists require. So we found that they really need to acquire clinical knowledge of complex medical conditions, applying palliative care principles and physiotherapy clinical reasoning to determine the risks and benefits of therapy. They will need to practice communication and soft skills to manage the psychosocial aspects of care. And further research is needed to identify the most effective teaching strategies to address these areas. So one of the outcomes, one of the things that we did as a result of this research study was to implement or to come up with this workshop. So my colleagues and I in Tan Tock Seng Hospital, we actually partnered with the medical social workers to create a module as part of our PT and OT workshop. One of the modules includes communication and soft skills to manage the psychosocial aspects of care. in addition to the various other things that we were training for in terms of identifying the disease trajectories, in terms of setting goals for the patients. So further research is definitely needed to identify what were the most effective strategies. What we used the other time was role play. We got the participants to try role playing and to immerse themselves in that situation where they face different situations. It could be that the patients refuse treatment, or it could be that the patient's relatives doesn't want therapy. And a lot of times it has got to do with cultural aspects of palliative care that we experience in the Asian culture, so which I will be touching on later. So moving on, from a national perspective, research support is available from the Lien Center for Palliative Care, where they have research programs looking into clinical, social, and cultural aspects of palliative care in Singapore and Asia. It also focuses on palliative care education and the development of healthcare professionals. So they hold regular multidisciplinary forums where common issues can be discussed among a multidisciplinary team coming from different care settings. And all this aid in the development of healthcare professionals in the local scene. So in terms of funding for palliative care programs, in Singapore, the charitable sector was behind the hospice movement from the start. So a group of volunteers, they identified a gap in the services, and it was a gap that the government a long time ago wasn't prepared to work on. So while currently the voluntary sector continues to run the services, nowadays government funding is more forthcoming and affordability dramatically improved. We are seeing increasing government funding for hospice care from 30% to 60% of their financial requirements. We're also seeing government healthcare funding coverage increase for the elderly. And there is also an enhanced national healthcare insurance program for the elderly within the last couple of years. And just in the news last week, even private insurance companies, they are starting to cover for palliative care services and inpatient hospice stays. So watch this space in terms of funding. Definitely exciting times. And a lot of promise in terms of getting funding for the community care settings. So finally, going on to the cultural factors which I mentioned just now, it's important to look at the ethnic composition of the resident population in Singapore. So Singapore is mostly made up of 3/4 Chinese residents, and with Malay constituting 13.3%, and Indians forming a minority of 9.1%. So looking at this makeup, it's important to consider various factors such as cultural taboos. In the Chinese culture, talking about death is largely taboo, and public awareness of palliative care tends to be very low. So increasingly, in the recent years, the charity sector as well as the government, with the government support, we're reaching out to increase public awareness, encourage the public to talk about death and advanced care planning, and just sort of encouraging them to increase communication in this area. So, in terms of the Indian culture, bearing in mind that a large majority of the Indian population in Singapore, they hail from India itself, meaning the elderly generation, a lot of them, they have their parents, their grandparents, or even themselves coming from India. So whereby in Indian culture, the truth is, the death is less of a taboo, but the truth is often hidden from the dying by protective relatives. And we're seeing increasingly we're observing also that a lot of times in Singapore, the advanced care planning or in terms of treatment discussions commonly occur between the doctor, the clinician, and the family. And the family members make decisions for patients. Whereas in the Western culture, it's very much different. A lot of times the patients want to know the conditions and to be able to participate in the decision making. So we're seeing in Singapore, family members tend to be protective, but of course, Singapore is slightly more westernized in terms of the exposure to the Western culture. So increasingly, the younger population, they are more and more aware of Western thinking and also being able to make a stand and also to take charge of their own care needs. So we're also thinking that raising the public awareness is actually vital. Hospice professionals should see their task as similar to those working with HIV and AIDS awareness, to educate the public to see that hospice care is really about living as well as possible, as well as being as long as possible. Public education campaigns are vital at this task. So this year, how do Singapore rank after 5 years in terms of the quality of death index? So in 2015, the 2015 version, the number of countries included has been increased from 40% from 40 countries to 80 countries. So this index, which focuses on the quality and availability of palliative care to adults, is also structured differently from the 2010 version, meaning that direct comparison of the scores between the years is not possible. So we're seeing that in Singapore, there is a rise in ranking from 18th in 2010 to rank number 12 this year. And among Asian countries, we are ranked second. And we do particularly well in terms of human resources. A lot of credit has to go to the government and as well as the public, the charity sector, increasing manpower and attracting people to the long-term community hospice and palliative care settings, and increasing training in terms of the allied health professionals, medical doctors, nursing staff, and we're also doing particularly well in terms of affordability of care. So like what I have touched on in terms of funding is more forthcoming from the government, and we're maintaining quite good standards in terms of quality of care, getting a score 90 out of 100. So that ranks quite high among the various countries. But I have to say we have to work harder in terms of community engagement, getting the public to be more aware of quality palliative care, as well as end-of-life conversations. So what are the learning points from the Economist Intelligence Unit Quality of Death Survey, the study? So we found that countries with high quality of death share several characteristics. The leading countries have the following elements in place. They have a strong and effectively implemented national palliative care policy framework, such as those in the UK and the US, high levels of public spending on healthcare services, extensive palliative care training resources for general as well as specialized medical workers. Now, the key right here is general medical workers, because given the limited number of specialized palliative care workers, the limited number is not sufficient to cope with the rising palliative care needs. So we need the general medical workers to be also aware of palliative care principles to apply them into the daily practice with all sorts of patients, be it cancer care patients, organ failure, end-stage organ failure patients, dementia patients, neurological patients as well. We're also seeing that countries, they have a wide availability of opioid analgesics, and they tend to do well in terms of quality of death index. Those with strong public awareness of palliative care, they tend to do well. And it's also found that best care tends to also include an interdisciplinary team, whereby physical, psychological, and spiritual support comes in. So for us, particularly physical therapists, we deal with the physical realms of the patient care, and we are certainly an important part of the interdisciplinary team, and we can contribute greatly to patient care. And bearing in mind also the psychological and spiritual needs of the patients. It was also recommended that patients, we try to involve the patients in terms of decision making, so be it clinical in terms of medical care, in terms of what they want to achieve for their therapy goals. It could be occupational therapy, it could be physiotherapy, speech therapy, different goals of care. So that's it. The learning points from the Economic Intelligence Unit and the summary of how Singapore has progressed through the years, implementing the guidelines, and slowly we're working towards empowering our neighboring countries, countries like Vietnam and Indonesia, working closer with them to actually improve the long-term and community hospice and palliative care services. So these are my references. So I would like to thank the audience, all of you who are listening to me online, as well as subsequently those who are listening to the recordings. I'd like to also thank the doctors, nurses, and healthcare workers, and even the patients whom I have had the honor of working with back in my time in Tan Tock Seng Hospital, Dover Park Hospice, and the people from St. Andrew's Hospital who came over for their attachments, the people who have been attending our training courses. Thanks for the wonderful experience. So it was during these few years, riding the wave of growing palliative care services in Singapore, where I've also seeing an increased exposure in this aspect. So I have the privilege to share with an international audience today. So if any of you would feel free to contact me, these are my email addresses. And I leave you with this quote, to affect the quality of the day, that is the highest of arts. Thank you very much. And I'll open the time for any questions.
Junhong, this is Jackie Drew, and I just want to thank you for a really great presentation on the framework, the structure, the historical development and future needs of hospice and palliative care from Singapore. For people that would like to ask questions,
you're welcome.
Oh, you're welcome. If anyone would like to ask a question, you can use your microphone, or you can scroll up to the chat line and type something in the chat. And Junhong, you might want to scroll up to the chat in case people have some questions in the chat line. But I'm going to open up the floor now if anybody would like to use a microphone to ask a question.
All right. Question from Chris. Hi, Chris. I saw your presentation previously on the international approaches, and that was very enlightening. Thanks for your question. So you were asking whether I could speak about to what level was palliative care taught in the physiotherapy programs in Singapore, and where were the physios commonly trained. So for a long time in Singapore, our entry-level training program came from Nanyang Polytechnic. It is a 3-year diploma program which was based largely on the University of Sydney curriculum, and with the option of a 1-year degree conversion, be it in the UK or Australia or other countries. I myself was trained in NYP for the diploma program. There wasn't any formal curriculum in terms of palliative care in the diploma program. And right until recently, where Singapore improved its level of entry-level training to offering a degree program. So that is in conjunction with the Trinity College of Dublin, working together with the Singapore Institute of Technology to offer the Bachelor's of Science in Physiotherapy program. So I've had the privilege to meet their lecturers and to attend some of the courses that they introduce. They have the lecturers from Trinity College. They've got very extensive knowledge of oncology rehabilitation, and they even have modules on palliative care. So it was just until the last 2 years that we started to implement such modules in the local Singapore curriculum. And it was only just until last year where me and my colleagues also conducted workshops in this area to empower our fellow colleagues. So thank you for the questions. I'm seeing a very good attendance over here. How's everyone doing? It is way past midnight over here in Singapore.
Oh my goodness. I also posted, if people would like to continue this conversation, Darren Brown, who's the HIV and AIDS coordinator, runs our listserv. So I posted his contact information on the chat line. If people would like to contact him, they can join our listserv and they can continue this networking online, or they can contact Junhong at an address that he provided on his website. Maybe you'll want to show that again so people can see it.
Sure. Okay. Yep. Are you able to see? Okay, so feel free to contact me at my email address for any feedback. And the local institutions, if I missed out your institution, please forgive me. Just so many updates in the recent years. I'm just trying to keep the presentation concise and to give a very brief and concise update of the state of the art currently.
This was an excellent presentation. Does anyone have any comments about the palliative care in their countries that they'd like to share, either verbally or online?
Hi, Jackie, or Junhong, can you hear me? This is Rich Briggs.
Hi, Rich.
Thank you so much for your presentation, Junhong. It's very exciting to hear about the possibilities of developing the role of physical therapy in palliative care in your country. Physical therapy may be the key in Asian culture of maintaining hope while people are declining. And I see my work in the United States, in California, physical therapy has the role of helping people live while the progressive disease process, the natural process at the end of life is occurring. And the therapist can be the agent to support the patient and the family as they're living, and then also giving them the skills for the care, whether it's in inpatient or acute care or at home, and also can be part of the medical care that helps people let go of the activities of living, which is natural in this course. So I'm excited that you're working to develop this in Singapore.
Thank you. Thank you, Rich. Yes, it's certainly an enriching experience for myself as well. Seeing what our society thinks is impossible to be able to empower the patients and caregiver. So very common during my practice in the inpatient hospice and palliative care setting, we're seeing patients who are warded in the inpatient palliative care unit, who surprise even themselves because a lot of times they can get up to walk. A lot of times with proper carer training, they could actually go home to spend more time with their family, and the caregivers were able to take care of them through training by the occupational therapist or the physical therapist. And we're seeing this patient empowerment as well as caregiver empowerment. We're finding it's really quite powerful. Thanks for your question and your sharing.
Are there any other questions? This is your chance to talk to somebody from Singapore and let them know what's happening in your area. Well, if there are no further questions, you know how to get a hold of Junhong or how to join our listserv and continue the conversation. Our Education Director, Nina Chegbo, will be sending Junhong an International Scholar Award from the IPT-HOPE group for this wonderful presentation. And again, I want to thank you. This was just extraordinary to learn from what your country's doing from a structural perspective, what's happening from an educational perspective, and in terms of the economics, and then some of the future needs. So I just want to thank you, Junhong. This was an excellent, excellent presentation.
Thanks for having me.
You're very welcome. So if there are no further questions, we will end this session. And thank you, everyone, for coming. Thank you for your comments and your questions. And thank you so much, Junhong. This was a really wonderful presentation.
Thank you, everyone.
So I will bid everyone adieu. I'm going to stop the recording now, and then it'll appear. I can send the recording to the online center. Thank you, Junhong.
Thank you. Good night, everyone.
Good night.